traffic was, it took me an hour and a half, so I'm very sorry. My title, actually, I modified a little bit today as I was trying to capture where we are. When we talked about the title, I guess a couple of months ago, it looked a little tidier than it is now, but I think this caption gets it. I was right behind, almost a block away, a big SUV with a bumper sticker that said "Repeal Obamacare," and I thought, well, if that person's going to the meeting, it'll be an interesting discussion. So we obviously, what some of us who, and I will show my colors right up front, I'm an enthusiastic but critical supporter of Obamacare. And those of us who had hoped that by now maybe people would be reconciled to it and be putting their shoulder to the wheel, well, that's not where we're at, as I'll explain. But if you could, I just want to recap. I mean, some of this, hopefully in the 3 years since it passed, you would, there you go, thank you. You kind of absorb by osmosis through all of the chaff and the chatter. But I think it's really important to talk about just baseline. Where are we? What is the significance of this law? This is the culmination of 100 years across multiple presidential administrations, both parties, to try to enact health reform. And it finally happened. You can go back and look at the history of Woodrow Wilson. Actually, Teddy Roosevelt talked about it. That's Teddy Roosevelt. Long before Franklin did. So, and a Republican nonetheless. So, anyway, that's really significant historically. We're all, I think, aware that the past 3 decades have seen steady widening the income and wealth gap among Americans, and certainly that was deepened by the Great Recession. This shifts money. You won't hear Obama or the proponents talking about it, but just amongst those girls, I'll let you know that this is a large shift of income from the top tier income pyramid to the middle and lower middle income ranks in our society, reversing policies of literally 3 decades. And another well-kept secret is it's the most important civil rights legislation since 1965. We don't like to talk about it, but there are huge gaps based on race, and those in terms of access to care as well as health status, and this begins to close those gaps. You can't equate health insurance automatically with improvements in health care, but you can't close those health status gaps when there's a disproportionate number of minority Americans who don't even have health coverage. Health coverage is necessary. It may not be sufficient, but it certainly is necessary in getting the care that you need. We have this uniquely American dilemma, unique among the industrialized countries, of this huge cohort of our population that is uninsured. We all hear the statistic, 50 million uninsured, but we tend to overlook the fact that there's, by some estimates, an equal number who are underinsured or intermittently uninsured. So it's 50 million at any given time, but over the course of a year, people go in and out of insurance status, which is very destabilizing and certainly disruptive of your health care. And then there are people who keep the coverage through the year, but it's really not worth anything because of exclusions and cost sharing that is unaffordable. The healthcare system is unjust. As I mentioned, there are enormous racial disparities. It's financially unsustainable. If you could put the next slide for me. And I'm just going to quote from a local expert, Jeff Balzer, who's the Vice Chancellor for Health Affairs at Vanderbilt. Healthcare, he likened it in previous, this is an address to the medical center staff when he was beginning to lay the ground for the pretty traumatic changes that are occurring there now in terms of layoffs. He said, we've been through a housing bubble, we are now seeing the collapse of the healthcare bubble. We've been accustomed, almost inured to years and years of talking about unsustainable health costs. Well, now, apparently, those are no longer going to be sustained. And it's, as he says, the bubble has burst. So how does the ACA, the Affordable Care Act, or Obamacare, reform health care? It does three things. It expands coverage. It bends the cost curve, saving $109 billion over 10 years. Last year, right after the Supreme Court decision, Speaker Boehner, Speaker of the House of Representatives, asked the Congressional Budget Office for a new estimate of what the fiscal impact would be of repealing Obamacare, and was chagrined when CBO came back and said that it would cost $109 billion to repeal Obamacare, because that's the amount of savings that's projected. Now, I happen to think that when you project out savings over 10 years, you need a Ouija board and the eye of a newt and the entrails of a chicken. I mean, just think back, you know, if you tried to do this on the eve of 9/11. I mean, you can't really realistically project out there and anticipate. But that's the way scoring is done on legislation. And I think what we do know from this is that the best minds, the best conjurers, and people who are rigorously neutral say that this legislation is expected to save money over the long term. Again, it doesn't take money out of the system, but it bends the curve down. The inflationary trajectory begins to flatten. And it improves quality by measuring and rewarding outcomes. Right now, we pay mostly for inputs. We pay mostly a la carte. And as you know, when you go to a restaurant and pay a la carte, it costs a lot more. You also may get served food that is expensive but not necessarily wholesome or healthful. And one of the shocking things about our healthcare system is that it is, despite the dedication of the people who work in it, and despite the virtuoso accomplishments in certain areas, it's generally mediocre. If you look at international comparisons that are compiled from data collected by the Organization for Economic Cooperation and Development, OECD, which is a club of like the 29 advanced, wealthy, industrialized countries, you see two things. First, you see that we spend 50% more than the median, and substantially more than the highest cost, whoever's next in line behind us. But what you also see is when you look at life expectancy at any number of points along the age spectrum, if you look at infant mortality, if you look at morbidity, we do not fare well. Yes, we're better than most of the world, but if you look at our peers in terms of affluence and scientific accomplishment, we come in generally around 20-something, depending upon the measure. And that's not a reflection on the people who work on the system. If you work in an inept system, in an inefficient system, you're doomed to be ineffectual. I worked many, many years ago in an earlier life on 18-year prison litigation in the state of Tennessee back in the 70s and 80s. We had literally the most violent prison system as measured by deaths per 1,000 inmates in the country. It was horrifically expensive and inept. And we prevailed in federal court, and out of that we brought in some experts, including management experts from the Wharton School at Penn. And they came in, they did an evaluation, and they came back to report to the lawyers in the case before they reported to the judge. And I said, okay, do you have your hit list of all those incompetent people that I've been dealing with for years that you're going to lay off, that you're going to say should be given their pink slip? And they said, you don't get it. They work in an ineffectual, broken down system, and they are doomed to be ineffective. What I then saw over the subsequent 2 years was when the building blocks of a decent system and an effective system and an accountable system were put in place. It was like that old cliche about, you know, if you don't believe in resurrection, be here at 4:30 in the afternoon and watch all the slackers rise from the dead when it's quitting time. I saw all these people that I thought were dead would suddenly transform this system. And so if you have a system that's broken, I also had the experience of working in the McGovern campaign, doing transportation to the polls. Lord have mercy. I mean, you know, nobody knew. We rented a whole bunch of vans and we didn't know where we were sending anybody, and you know, people driving around all day with nobody in the vans, and there were other people that waited forever for a ride and didn't. And I excuse myself as reminding myself, well, if I'm working in a non-organization, I can't be blamed for it. So that's what the challenge is for the Affordable Care Act. Take on a system that is grossly inefficient and underperforming compared to other countries. It's unaffordable, it leaves lots of people out, and it's not that great a care. Broadened coverage is the keystone of the whole thing, because if you have these three elements, you can't deal with quality in a reliable way, which in the healthcare context means managing a person's health over a continuum of time and need. You can't do that if they're not in the system on a reliable way. If because of financial barriers and lack of insurance, they only appear in crisis, and they go from episode to episode because they don't have reliable and consistent care. That's inconsistent with controlling quality. It's also inconsistent with controlling cost. And you can't hold systems accountable for delivering efficient care to people for whom they are not responsible on an ongoing basis. So it's, again, getting people covered is an essential first step. And that's what I'm going to talk about here, because if the question is, where are we in Tennessee? Well, the keystone, I'm going to really jumble my metaphors here, but we're not slouching in the direction of having the keystone in place. I'm sure you followed that. There's two prongs in the ACA's approach to expanding coverage. One is the one that there, until recently, has been the most talked about, which was the individual mandate. There is a commitment in the law to reforming the commercial insurance market. And the grand bargain that went into the ACA was to say to the commercial insurance industry, you will, if you don't do what you did to previous efforts over a century, if you don't block this legislation, you get a new book of business, because we're going to subsidize people to buy commercial insurance through the marketplace that we're going to create in online exchanges. In return for that, you're going to have to sell to people that, guess what, actually need coverage, as opposed to trying to cherry pick people who don't and get rid of them as soon as they get sick. So we're going to make you play fair, but in return, we'll require that people get coverage, because it can't work if people wait until they get sick to sign up. You can't wait until your house catches on fire to buy homeowners coverage. And so there was this grand bargain. The insurance industry said, we don't want the poor people, particularly because we know there's a correlation between chronic illness and poverty. People who are chronically ill and have disabilities tend to be poor for obvious reasons. And we don't want them, because, hey, we're insurance companies and things work better if we can insure people who are basically healthy most of the time. So why don't you send those people to Medicaid? So that was the deal. Two prongs were, we're going to have insurance reform for people above poverty, and we're going to have premium tax credits or subsidies to make it affordable. So we're going to deliver this new book of business to the commercial insurance industry. We're going to get people covered that are in the, not wealthy, but between 100 and 400% of poverty will get premium subsidies. That translates, by the way, to about $23,000 to $92,000 a year for a family of four. People in that band, and of course it varies by family size, on a sliding scale will get premium tax credits. The second prong is expanding Medicaid to the people that, Medicaid being the insurance program that's administered by the state, largely funded by the federal government. TennCare is what we call it in Tennessee, and it's for people who are poor. In this case, we would expand it to 138% of poverty. People, I think, who are aware of Medicaid at all or TennCare, and people tend to confuse Medicaid and Medicare. But most people, I think, assume that if you're poor, you get Medicaid coverage. That is emphatically not the case. The saying goes, if you've seen one Medicaid program, you've seen one Medicaid program. They vary tremendously by states, and you will not be surprised, I think, to hear that the southern states have the most restrictive eligibility in coverage for a dependent, for a family with dependent children. The upper income limit is less than half of the poverty level. And it varies depending upon what category you're in. And that's the other major thing that the Affordable Care Act does to reform Medicaid, which is to do away with categories. You can have zero income, and if you are between the ages of 21 and 65 and you don't have a disability and you don't have kids, it doesn't make any difference. You can have zero income. You're not going to be covered by Medicaid. Because why? Well, go all the way back to Elizabethan England and the Poor Laws, where poor people were viewed as a menace to the social order and morally deficient, and therefore we would imprison for vagrancy those able-bodied people that did not have a means of livelihood because they've been displaced from the lands with the Industrial Revolution. But Christians that we are, Christian society that we are, we're going to take mercy on the widow and the orphan. And you carry that all the way through, and the widow and the orphan and the halt and the lame and the elderly are the people that are currently covered by Medicaid. If you don't fit in one of those categories, if you're able-bodied, working poor person, you are SOL, which stands for severely out of luck. And so doing these two big reforms to Medicaid will raise the income level to 138% of poverty, and which is about $32,000 for a family of four. And if you are confused about 32,000, 23,000, 100%, 138%, there's overlap. Above 100%, if you don't have access to Medicaid or other programs, you get a premium tax credit. If you are below 100% of poverty, you cannot qualify for premium tax credit. Why? Because it was assumed that you'd be covered by Medicaid. And it was also assumed that you'd be covered if you were below 138% of poverty. And so the premium tax credits were really, although the law speaks in terms of you get a premium tax credit between 100 and 400% of poverty, really it's not designed with people in that very low income band in mind. The premium credits start at a level to pick you up at 138 because the assumption is you're going to be on Medicaid. So the assumption was, if you look at slide 10, you'll see that the expectation was that the majority of people would gain coverage, a slight majority of the people expected to gain coverage nationwide would gain coverage through Medicaid expansion. And then along comes the Supreme Court in a case called NFIB, National Federation of Independent Business, which June of last year, the end of the term, upheld the ACA. And the big headlines at the time were Obamacare is upheld by the Supreme Court. The focus was on the individual mandate, part of the insurance reform that said we're going to make insurance available with consumer protections so that it will be fairly available to people who otherwise couldn't access it because of pre-existing conditions, including my favorite pre-existing condition, which is having ovaries. You know, that insurance companies have long discriminated against persons with that with that particular pre-existing condition, and that's translated into higher rates for that they've justified as medical underwriting. That's abolished, and in return for those and other reforms, people are required to get coverage if it's available to them and to carry it. It's the individual mandate. It's the threat that, well, if they make us carry insurance, they'll make us eat broccoli. all of that stuff. The individual mandate, lots of buzz about that. In Massachusetts, where Governor Romney invented the concept, or he didn't invent it, it was actually invented by the Heritage Foundation, but he adopted it as part of Massachusetts Health Reform. It's referred to as personal responsibility provision. So they upheld the individual mandate, but they said that it was being oppressive to the states and a violation of Federalist principles for the federal government to require, as the ACA attempted to do, require the states to expand their Medicaid programs to the people from 0 to 138% of poverty, or to require that they do away with the categorical restrictions. And so it took a while, I think, before it began to seep in a lot of quarters that the good news was the law was upheld for the people above poverty. The bad news was that people below poverty won't get anything. And the result was that what had been a uniform federal piece of legislation that would have now done away with this anomaly where if you've seen one Medicaid program, you've seen one Medicaid program, where Mississippi and Alabama and Tennessee, for historical reasons most of us are well aware of, chose in the 1960s, because Medicaid came along right along with the civil rights movement. Those folks, those states wanted to make sure that their poor people didn't get a darn thing more than what they absolutely had to by virtue of federal law. And the idea was we would now do away with those disparities, and we would have a single unified coverage picture for people up to 138% of poverty across the country. Well, if you look at the map, you'll see that that's as a result of the radical surgery the Supreme Court did. We're far from having a single country. We're still in the world of, if you've seen one Medicaid program, at least in these states, which are the ones, the orange ones are the ones that have said, hell no, we won't go. The dark blue ones are the ones that said yes, and the light blue, including I think questionably us, Tennessee, are the ones that are still up for grabs. And so basically it's 21 for, 21 against, and the rest, including Tennessee, undecided. And in the South, only Arkansas and Kentucky are expanding coverage. So we have this anomaly where this incongruous result, where as a result of the Supreme Court decision, people are going to apply and be told, you don't make enough to get a subsidy. If you had 300% of poverty, if you had in a family of four $90,000, you would get a subsidy. But because you're in a family of four with half the poverty level, $11,000 or $9,000, you get no help at all, and you get no coverage. Stay uninsured. And that has enormous implications for the rest of the Act. Those of us who are fortunate to have coverage, we're not islands. Having people out there, particularly people with chronic conditions who don't have coverage, means that the cost, the episodic cost of their episodic care will continue to be shifted to us, and it will continue to undermine the system. It will be difficult to control communicable disease. It will be difficult to do the other parts of the reform in terms of quality and efficiency that are important. Those will take place, and we're seeing those changes taking place already in terms of systems coming together and beginning to reorganize themselves in more efficient ways, but it will do so with a lot of drag. And we're going to see a brutal sorting out in the hospital industry, particularly in rural areas. Where we are is that Governor Haslam said in response to the question, are you going to do the Medicaid expansion? Basically, that's a definite maybe. He announced at the end of March, approaching the end of the legislative session, that he would not do the Medicaid expansion, but that he had come up with an alternative unique to Tennessee, even though it's a knockoff of Arkansas, but unique to Tennessee, our invention only we could have come up with it, called the Tennessee Plan. And it would take the federal dollars that were to go to expanding Medicaid. And I should back up just for a moment about the finances of this. Medicaid, since 1965, has been a federal-state program with the feds paying from 50 to 80% of the cost and the state paying the balance. And the formula is state-specific, and it's based on poverty levels. So Mississippi has an 80% federal match. New York, California, Illinois, the affluent states, only 50% federal match. Tennessee, as a relatively poor state, has 66, 65%. So basically 2/3 of the cost of TennCare is paid for by the federal government, 1/3 by the state. The expansion for the first 2 years, starting in January of 2014, is 100% federal money for all the new people that become eligible. It then, over a period of 4 years or 3 years after that, phases down to a match of 90% federal, 10% state. This is a deal to die for. If you just envision TVA, 101st Airborne at Fort Campbell, the U.S. Navy at the Millington Naval Air Station, or VW in Chattanooga, or Oak Ridge National Laboratory, some humongous infusion of either federal dollars or private big employer dollars into the state at the level we're talking about, every politician in the state would be happy to don a hard hat and wield a shovel and cut a ribbon somewhere if we could just figure out some way to translate Medicaid expansion into a visual at a construction site with a bulldozer in the background and somebody wielding a shovel. But because we can't, because it instead is money that filters out to pharmacies and doctors' offices and hospitals to pay for care, the economic impact of that is largely lost in the political debate, at least as the political debate is being conducted currently. If you look at the math, we tax HMOs, health maintenance organizations. Everybody enrolled in TennCare is enrolled in an HMO. Those HMOs are all privately administered. So they pay 5.5% tax on all the dollars they get. So in other words, all of that federal money is going to go pour into the MCOs, the managed care organizations, also known as HMOs. We'll pick up 5.5% of that right off the top. And then we charge the hospitals 4.5% of whatever dollars, 40%, maybe 50% of those dollars that are left go down to the hospitals. We take another 4.5% out of that. That's before you ever look at the economic impact that economic development promoters and businesses like to do of looking at how often dollars turn over an economy. So if we give huge concessions to VW to locate in Chattanooga or Amazon to locate a warehouse in Lebanon, then that payroll is going to turn over and it's going to generate this amount of sales tax and on and on and on. Suffice it to say that the University of Memphis Business School did an analysis, showed it would generate 18,000 jobs in the first year if we did the Medicaid expansion. Those are not all in the healthcare system. Again, it's the multiplier effect. And my office did an analysis looking just at the HMO tax, as conservative an approach as you could take, not looking at the multipliers, not looking at labor department multipliers or economic development office multipliers. And we found that just the HMO tax alone, the state would make money off this thing through 2021. So when you hear about this being a money suck, or this being oppressive, or a budget buster, that's cloud cuckoo land. From an economic standpoint, the Medicaid expansion is literally a no-brainer. There is, I can't think of very many other policy arguments that I've encountered as an adult where you could say with a straight face, there's really not another side to this. There is really not another side to the economic argument in favor of the Medicaid expansion. It's not what we're going to do, though. The governor announced we're not going to do the Medicaid expansion, we're going to do the Tennessee plan. The Tennessee plan would take that 100% money and use it to go onto the exchange. We're going to create this online marketplace. It was called an exchange, now the terminology is marketplace, where people will be able to go and shop. And if you go to the exchange and you buy a policy on the exchange, then you can qualify for premium tax credit, but only if you're above poverty. What this would do is take the Medicaid dollars and say, we don't want this stinking federal socialist Medicaid program. We want people to have coverage through a private commercial insurance company. So we're going to give them the money. They can't qualify for premium tax credit, they're too poor. We're going to take the Medicaid dollars and buy them insurance through the exchange. So, instead of them being stuck with coverage through one of TennCare HMOs, such as Blue Cross Blue Shield of Tennessee, which administers TennCare in parts of the state, they will go to the exchange, we'll pay a premium tax credit or premium assistance using these federal dollars to buy them a private commercial insurance policy from Blue Cross Blue Shield of Tennessee. It's very subtle, very subtle. There's a huge difference here between getting people coverage through TennCare, where they would be stuck with a socialized government handout type program, and be stuck with public provision of care administered by commercial private insurance companies, and being able to go to the exchange and where we pay a premium for them to have coverage through a commercial private insurance company. But that's just stays in this room. Okay. CBO estimated that premiums, that it costs 50% more to insure people through commercial insurance than it does through Medicaid. 50% more. Arkansas, which came up with a plan that is uncannily like the Tennessee plan, except that we know it's not the same because the Tennessee plan is unique. Our governor says so. They came up with an actuarial estimate with putting very large thumb on the scale and clicking their ruby slippers together and closing their eyes, and they came out with a projection that said it's only 16% more expensive to do premium assistance than Medicaid coverage. 16% increase on a very large base. 16% of billions of dollars runs into change at some point. But we're going to bring the genius of the private commercial insurance system to these poor people, and that's the key element of the Tennessee plan. Another element is we're going to reform the way TennCare pays for care to start measuring outcomes and paying for performance. That sounds uncannily like the linchpin of the payment reforms built into Obamacare itself, but since we know the governor would have nothing to do with anything that resembled Obamacare, it's bound to be different, even though it's described in terms that sound identical. Again, subtle but important. It will require higher cost sharing of beneficiaries. The term is these people should have skin in the game. And what they would do is they would charge, the governor's proposal would charge people below poverty the same amounts of cost sharing, that is co-payments and deductibles, as is charged in the exchange to people with 250% poverty. They're going to indulge the fiction that they have more money, 2.5 times more money than they do in some cases. Because apparently the thinking in our state is that the cost-sharing protections in the exchange are, for ordinary people, are far too liberal and far too good for the people who are poor, who are, well, they should have skin in the game. It should have to hurt for them to have to get coverage. And so they would set the cost sharings substantially above what their more affluent peers getting coverage through the exchange, through the marketplace, would be subject to. And it would eliminate some of the consumer protections, appeal rights and that sort of thing, and it would provide skinnier benefits that then would be available in TennCare. Those are all of the things that make the Tennessee plan special compared to a Medicaid expansion. It does have, in my view, and I'm biased, I represent poor people, I think those things I don't find particularly compelling. There's lots of evidence that shows that cost-sharing barriers, co-payments and deductibles act as absolute barriers for people who don't have the money, and that is poor for quality of care and poor for their health and poor for overall cost control. If you keep somebody who's hypertensive from being able to afford their hypertension medication, that's not a good way to save money. If you make it impossible for somebody with diabetes to buy the strips so they can monitor and maintain their insulin levels, that's a foolish way to try to save money, apart from being inhumane. But that's the ideology of the Tennessee plan. But it does have one significant policy advantage, which is that it would address churning. Churning is the problem that's anticipated that will happen when people who are close to that break point between 138% and above 138%, they're in Medicaid, and then they get an increase, so then they have to leave whatever plan they're in, including whatever network of doctors or participants, and move into the qualified health plan for the people who are getting their coverage off the exchange, and it goes in the other direction. There's a lot of concern about that. There's concern about disruption of care and care relationships, but there's also concern just about people losing coverage altogether in that shuffling back and forth, because we know the complexity of coverage leads to lapses in coverage.
How often do they look at that? Like what income level? Is it
Annually.
Annually?
Annually, but you're required to report certain changes that could affect your eligibility. So if someone took a new job that involved a major increase in their income and they were on TennCare, they would have to report that. So that is a legitimate policy concern that the Tennessee plan addresses, and I think is a positive of it. But the biggest reason for supporting the Tennessee plan is it's the only game in town. It is the only hope for covering people. We've known, people who were following this have known that the politics in our state were such that there was no way that Medicaid expansion would occur without strong support and leadership from Governor Haslam. And so on March 27th, when he said he announced the General Assembly he was not going to support Medicaid expansion, it was done. It was not going to happen. And then he said as a consolation prize to the hospital industry and commercial interests who had been pressing him to adopt the Medicaid expansion, he said, but I'm going to do the Tennessee plan. And that's where he described it. Well, it remains to be seen whether we will see the Tennessee plan actually materialize. There are two hurdles. And one of these, and I apologize for the intensely irritating information, when I snagged that offline, off the internet, I didn't realize it was animated. It's awful. But anyway, we've got to get federal approval to use the dollars to buy people coverage through the exchange rather than using it for Medicaid. If you want to move to the next slide, thank you. It requires a, quote, waiver from Secretary Sebelius at HHS. So that's one thing. You've got to get federal approval to use the money in a way differently than what was anticipated in the legislation. That is, to use it for premium assistance rather than Medicaid expansion. And you've got to get approval from the legislature. The governor did not have to get the approval of the legislature. He put himself in that position. He promised that he would come back to them, sort of like President Obama saying, I don't need anybody's permission from Congress to go bomb Syria, but I'm going to ask for it anyway. Well, the governor did not have to get it through the legislature. It could have been in the budget, and it would have been approved as part of an overall budget vote, and Republicans in the legislature would have had cover against attacks from the right, from the Tea Party faction. They could have said, I didn't vote for it. In fact, they could have had all sorts of show votes about, you know, condemning Obamacare and so forth and so on. As long as it was in the budget, then it would have happened, and they could have said, I only voted for the budget. Of course I had to vote for the budget. This was well understood, and if anybody was watching the governor's dramatic but somewhat confusing speech to the General Assembly at the end of March, he went into this long thing about woe betide us if we don't figure out a way to take care of these people who are working families and don't have coverage and so forth. Woe betide us, and shame on us if we can't maintain our rural healthcare infrastructure by drawing down these federal dollars. And then he said, so everybody thought, well, he's about to announce that he's going to do the Medicaid expansion. He said, but of course it would be wrong to have any kind of truck with Obamacare. And I promise you that the Medicaid expansion or any expansion, Tennessee plan, will not be in the budget. At that point, the Tea Party faction in the General Assembly broke into applause, and the Tea Party folks in the gallery all applauded. The news media, including the national news media, were confused. Some of them reported that we were doing the Medicaid expansion because he went on to describe he was going to cover all these people and so forth and so on. But the Tea Party folks had the decoder ring, and they understood what that meant. If it wasn't in the budget, and he had to come back for an up or down vote, it was not likely to happen, because then every member of the General Assembly, including all those Republicans who are scared of being primary, would have to stand and take a vote up or down on Obamacare. And that's a tough vote to take. So he's got to cross two hurdles. I will not ask you to go back and look at the first slide, the animated one, but there were two hurdles there.
There's the first one, sorry, I got ahead of you.
Well, I was thinking of the obnoxious one up there.
Oh, no,
that showed the animation. Thank you for sparing us that. On the first hurdle, the Obama administration has said, I mean, they're holding their nose and closing their eyes and saying, premium assistance, it's fine as long as it's budget neutral, as long as it's cost effective. Well, CBO says it's not going to be budget neutral, it's not going to be cost effective. It's going to be 50% more. Arkansas says, after locking up the actuaries and flogging them until they brought the number down, said it's only going to be 16% more. They've said it has to be equal. We're not going to let you do premium assistance if it would cost more than Medicaid expansion. But the fact of the matter is, they made pretty clear that they will close their eyes to what it took to get the actuaries to get to zero. So premium assistance is given. Payment reform, this is another one where this doesn't leave the room. TennCare doesn't pay providers. It pays MCOs. MCOs pay providers. The state does not have the right to dictate to MCOs how they pay providers. That, in fact, those contracts between the MCOs and the providers are proprietary. None of us knows what those deals are. We are exempt from any federal restrictions on how we pay providers. I have yet to hear an explanation of how, in a context of capitated managed care, which is what TennCare is now, where we pay a premium to the managed care company at the beginning of the month and say, you deal with the providers, you pay them, you negotiate the rates. I don't understand what this even means, and I've heard the hype about it, and it's just, I still don't get it. But the way they describe it is it's going to pay for performance, it's going to pay for outcomes, it's going to measure quality, and that's what's going to drive payment. I'm for it. But in any event, as far as the feds are concerned, the state can do what it wants. So that's okay. Eliminate these consumer safeguards, cost-sharing limits that exceed what would be charged to people in the exchange, much less what they would be charged if they're on Medicaid or TennCare. Not providing the same benefits as if they're in Medicaid. And mostly the benefits that will be available in exchange are almost the same. There are a handful of benefits for poor people, like providing transportation to doctor's appointments. I mean, it's less than budget dust. Why that would matter to the state, I don't know. And appeal rights. They want to truncate the appeal rights. Those things from a fiscal standpoint and from a policy standpoint are budget dust. Now, they're not inconsequential to the people who are affected. If they can't come up with a cost sharing, they effectively don't have insurance. And so the feds are not going to allow that. They've made very clear they will not allow it. They made that clear 2 days after the governor's announcement. They said, we will approve premium assistance, we'll approve payment reform. Here are some things that are deal breakers. 2 days after that, the governor sent his proposal it wasn't a formal proposal, but the letter to the secretary saying, I want all these things. If I don't get these things, we're not going to do the Tennessee plan. And that's his latest position. So if you've been following the press, it's been saying, where he's been every periodically going up and saying, I've been to Washington and I've either had a good conversation or I've had a discouraging conversation, or I've talked to Secretary Sebelius, and there's been all this, we're talking. I can tell you that what's actually going on is about every 3 weeks, someone from the TennCare Bureau has called up and said to the secretary, yo, what's happening? To which the response is, you haven't submitted an application yet. A waiver application is literally like that. It has to be posted for 30 days for comment in the state. Then it has to be posted at the federal level for 30 more days of comment. I mean, Arkansas has been toiling away at this. Of course, it's not the Tennessee plan. It's not the Tennessee plan. But their poor facsimile of the Tennessee plan has been the subject of much work for 6 months. And the feds say, for political reasons, oh, we want to be helpful and we are hopeful that we'll be able to come to terms with Governor Haslam. The fact of the matter is, I can tell you the people that are in that agency say, we can't approve an application that's never submitted. And they know that if they keep drawing that line in the sand, it won't happen. Now, I was told by a very shrewd Republican lobbyist that he thought the Tennessee plan was the smartest invention since holy water. That the governor got to turn down the expansion and thereby mollify the Tea Party faction at the expense of the business interests and the hospital industry. But the consolation prize was, I'm going to do the Tennessee plan. And truth to tell, hospitals prefer commercial insurance because it pays better rates. That's why it costs a lot more to cover people through the exchange, among other reasons. And so, for this will-o'-the-wisp, this will mollify the hospitals, and he's framed it in a way so that when that doesn't happen, it's going to be the feds' intransigence and rigidity. That's the reason why people don't have coverage. That's the reason why we're not getting the federal dollars. I've heard other people who I also respect, who know the governor personally and insist that he is not a cynical person, that he genuinely wants to pull down the federal dollars, and that he's really working at it. That's not what I hear from people who are on the receiving line in the federal government, but I don't know the governor. I just know that we keep talking about we've got to have these concessions. They're completely insignificant from the state's perspective. They have no fiscal implications whatsoever. From a policy standpoint, they're inconsequential, and yet we're drawing a line in the sand on that when we've got these big concessions up here. So right now, it looks as if we're just kind of slouching along, and I think if you were putting money on it, you would say it's probably not going to happen. If you go forward a couple of slides, you'll see that we've got to, if the governor doesn't come off of those non-negotiable demands, then it's probably not going to happen. And what's the effect of that? Well, if the feds have said, we can sign up for the Medicaid expansion, or we can take the money if we get a waiver, at any point, the dollars become available January 1st, 2014. And the legislation makes the 100% match available for the first 2 calendar years. We can call up January 15th, we can call up March 15th, we can say at any point, we want the money. Now, if we just do the Medicaid expansion, then it just happens. But if we go through a process and get a waiver, there's some lead time on that. But whenever we choose to apply for it, the money is there, it's got our name on it. But it's earmarked for those years. So if we wait 2 years, we're not going to get 100% match. We'll get 95% match. We'll get whatever it phases down to. And of course, we won't be able to go back, whatever the rate, we will not be able to go back and recoup that money. And we did the math in my office, and if you go to the next slide, every day that we, using the state's figures, every day that after January, starting January 1st, that we do not do the expansion of the Tennessee plant, we lose $2.8 million in federal funds. Again, just do the mental exercise of imagining if this were Oak Ridge or TVA or somebody else that was trying to send us money, and we said, no, we don't want it. But the governor is committed to going back to the legislature, as I said. He said there was talk of a special session this fall. Nobody I knew thought that would work. So you're going to call all these people together, and the only thing on their plate is what they think about Obamacare, and you're going to ask them to take a vote on that? No cover whatsoever. And they're going to all be showing how I hate Obamacare more than you hate Obamacare. So 2013 doesn't look like a good bet. 2014 is a primary year. Deborah Maggard. Everybody know the verb maggard, to be maggardized? You know? 100% rating from the NRA. 100% rating from the Tennessee Business Roundtable. Protege of the Tea Party. And folks to the right of the NRA went after her. Governor Haslam, Business Roundtable, Chamber of Commerce, they all poured money into her campaign. She still got knocked off in the Republican primary. So that has not been lost. And of course, at the national level, we know about Senator Lugar and Senator Bennett and others. And so that's what drives, the Democrats don't count in any of this. Those of us who were working to try to get some kind of coverage for people, our main contribution is just say to the Democrats, please just don't say anything. You know, if you make this a partisan issue, you just make it more difficult for the many conscientious Republicans who understand, who would like to do the right thing, but are scared to death. And if you make it a Democrat versus Republican thing, they've got to vote against it. Having said all that, and then after that, it begins to decline, the match rate begins to decline. It's still, even 5 years out, 6 years out, 90% funding, that's still a great deal. The state still makes money, but psychologically, that's, you know, if we didn't take it at 100%, it seems like it gets harder to take it later. Now, there are things working against that. We're going to be running a huge natural experiment in the United States of America. We're going to have one group that has expansion, and we have another group, a control group, that doesn't. And I think over time, we're going to see that states like Kentucky and Arkansas are more attractive for business recruitment, for example, when you don't have the cost shifting of the uninsured, and when their rural hospitals are not closing. We did a calculation in my office using very conservative figures. THA, the Hospital Association, has used probably more accurate, but a little bit less conservative estimates say that 54 hospitals will likely close without the Medicaid expansion. The reason for that is that the Affordable Care Act takes back a lot of money. There's huge savings in Medicare, which is the largest source of funding for hospitals. Medicare cuts as well as Medicaid cuts are built into the Affordable Care Act. They were unaffected by the Supreme Court's decision. I mean, basically the Supreme Court reached in and this very complex, tightly wired mechanism and pulled out a key piece. And now it's having all these effects. And one of those effects is it turned the Affordable Care Act into a huge bait and switch deal on the hospitals that said, we will agree to giving back rates in Medicare and Medicaid in return for having coverage for these people who now are just an uncompensated care burden. guess what? The Medicare cuts are already beginning to take effect. Last October, the first of those took effect, with penalties beginning to go into effect for readmissions of Medicare patients within 30 days of discharge. And that's the linkage of outcomes and payment. It's very positive, everybody agrees. People shouldn't be readmitted within 30 days. Either you discharged them too soon, or you didn't have an appropriate aftercare plan. And so we're gonna, right now, if they come back, you make more money off of that for Medicare. That doesn't make sense. But the reality is that a system that's built around the current perverse incentives can't turn on a dime. There's going to be real losses. That's why Vanderbilt is talking as it is about making cuts in the staff. That's why the talk by Jeff Balzer about the bubble is burst. And if we don't do the Medicaid expansion, we looked at publicly available data. There are 110 more or less general hospitals, acute care hospitals in the state. 30 of those will almost certainly close. Again, the THA's estimates were 54. 30 of those hospitals, of those 30 hospitals, they are in counties where 21 counties that now have a hospital or 2 hospitals will lose their hospitals. If a community loses its hospital and it has no hospital, it can't recruit and retain doctors. If you don't have a hospital and you don't have doctors, you can't recruit and retain industry. We are talking now not just about healthcare, we're talking about transforming large swaths of rural Tennessee where you now have vibrant communities, and within 5 years, you're going to transform them into places where kids turn 17, they walk, they get their degree, they leave town, and they only come back for weddings and funerals. That's what we're talking about. So, and some of these rural hospitals belong to chains that are publicly traded, and they are not going to wait to start hemorrhaging money. They're going to, 2 hospitals have already closed in the past 3 months. So, community health systems, they're looking at the bottom line, and they're not going to wait around. So, there are some significant budget factors that favor doing this. The dollars into the state budget, powerful interests are backing the Tennessee plan, the Business Roundtable, Chambers of Commerce, Blue Cross Blue Shield. I mean, this is a who's who of who carries a big stick down to the legislative plaza. And normally, there would not be a contest, just like normally, in normal times we would say there's no other side to this policy argument from a fiscal standpoint. It's all about the grassroots. And the Tea Party rebellion at the grassroots has deterred, intimidated the Republican Party from going along with this. And that's kind of where we are. So, we are now counting down to coverage. There are some key dates. Because while that drama has been playing out, meanwhile, the rest of the country is going forward, and the part that deals with the people who will be getting coverage through the exchange or through the marketplace, that's moving forward. So October the 1st, the marketplaces will go live. Ours will be administered by the federal government because we declined to operate it ourselves. And about 30 states are going to be run by the federal government. That has important implications. The law provided basically for the states to run the marketplaces with the federal government as a default. And it was thought that any conservative states that might be opposed would be deterred by the prospect that the federal government would be running their exchange. But the Heritage Foundation sent out word that states should oppose. This is all very ironic because the Heritage Foundation was the architect of all of this, if you go back to their papers 10, 15 years ago. But they said, let's bring down the exchanges because the federal government is not equipped to run the exchanges in 30. They're not equipped to do this. They were supposed to be a default position for just a handful of states. So now 30 states have rejected it, including ours. And it's a real challenge for the feds to get the marketplace going, but they insist that they will be ready. The individual mandate will take effect January the 1st. Coverage purchased through the marketplace. You can go to the exchange starting October the 1st, apply. You apply online. You will be told if you qualify for premium tax credit based on the information you put in, and they will import some information from your tax returns and ask you, is this information correct? They will say, you qualify for this amount of premium tax credit. You can go to the exchange and choose from an array of qualified health plans, or QHPs. So the acronym proliferation, we got the ACA, we got PTCs, premium tax credits, now we've got QHPs. You can shop for the QHPs as early as October the 1st, but the coverage will only take effect January the 1st. And then January the 1st, of course, the counter starts running at $2.8 million a day of lost Medicaid dollars, because the Medicaid expansion was due to take place then. The initial enrollment period will close March 31st, and so if you've not enrolled in that, you can't enroll until 2015 unless you experience a qualifying event, such as losing coverage due to divorce, or there's death in the family, or you lose Medicaid coverage, or some other reason that would justify your failure to have enrolled during the open period. So there is going to be a huge push to try to get people enrolled before March 31st. The focus of the federal government, the focus of Enroll America, which is a private organization which is trying to pick up the problem that now there's so much obstruction at the state levels. They're trying to step into the breach with volunteers. Their focus is on enrolling basically healthy people. The assumption is sick people will go because they're desperate to have coverage. But if only the sick people enroll, you get what the insurance industry calls adverse selection, and it destabilizes the marketplace. So it's very important that well people are in there to dilute the economic impact of just having sick people and their losses. So the focus is going to be trying to get people enrolled. The states that operate their exchange, the ACA provides for substantial money to pay so-called navigators to help people navigate through this complex system and make the choices they need to make about which plan is appropriate for them. They won't be recommending products, but they will help them choose. There's going to be these so-called metal tiers. You can choose a bronze plan, silver plan, or platinum plan, and they cost more, obviously, the higher tiers, and they have different levels of cost sharing within there, but there are minimum benefits in all of them, so it's pretty good coverage even at bronze level, but the cost sharing is higher. And bronze may be appropriate for one family, but not appropriate for another, and so helping people making those choices is really going to be important. Making sure that they get the appropriate tax credit, because they have to anticipate income. So there's a lot of complexity here. There's a lot of money for navigators in the states that have state exchanges, but by refusing to operate a state exchange, we put ourselves in a category where to sign up, well, there are 900,000 uninsured Tennesseans currently, and there's $1.4 million for navigators. It works out to pennies per person. So there's a big push to try to recruit volunteers to help take 5-hour training and go out and sign people up or help them sign up, do health fairs and that sort of thing. That's going to be very important, not only to those individuals, but again to the success of the act going forward. And so you may have seen where the Republicans have attacked Secretary Sebelius because she touted Enroll America, and they went after her for that. Now they have sent, the House Oversight Committee has sent lengthy demands for information to all of the nonprofits that got Navigator grants, demanding that they provide all their communications with the federal government, their communications with Enroll America. There was a telling moment 2 weeks ago when the Commerce and Insurance Commissioner in Georgia spoke to an audience and said, our job is to obstruct and disrupt the implementation of the Affordable Care Act any way we can, and that's exactly what we're doing. So we're anticipating in the next 2 weeks that our Department of Commerce and Insurance will issue regulations that will make it expensive and burdensome for volunteers to help people enroll by requiring them to go through background checks, fingerprinting, pay a $50 fee. So churches, I mean, there are lots of churches that have already signed up. They're going to do health fairs. I heard today what the draft regs look like, and that's going to be very problematic. So that's sort of where we are, but the fact of the matter is that there will be a marketplace, and it will operate, and a lot of people will come to it. And so if they are concerned by the individual mandate and they apply for insurance, then they will first be screened to see if they're eligible for TennCare, because you can't get a premium tax credit if you're eligible. So it's expected that upwards of 60,000 people who are currently eligible but don't know about it and have never enrolled will be drawn by the lure of private insurance and the compulsion of the individual mandate to enroll, and they'll end up in TennCare. So it's expected that 60,000 people, upwards of 60,000 people who are currently eligible, even without the expansion, will be added. This is referred to, I think, unfortunately, as the woodwork effect, which to me sounds like cockroaches. I prefer the term welcome mat, but if you put out the welcome mat, these people are currently eligible, not enrolled, will come. So when you see estimates that are bandied about how much Obamacare is going to cost the state and why it's unaffordable, it's the people who are already eligible but not enrolled, because they're not reimbursed at 100%. They're reimbursed at the current match rate of $2/3 federal dollars, and we'll have that cost whether we do the expansion or not. So that's going to be the effect of the marketplace coming online. And then the other thing is for the PTCs, premium tax credits, and qualified health plans. And as I say, the tax credits will be available on the sliding scale, but even for people above 400% of poverty, many of them will be grateful to be able to get coverage at any price because their medical conditions have previously made insurance unavailable on any terms at all. So for people who are currently without coverage, there will definitely be some gains. New form of charity care, there are going to be people below poverty who, if we don't do the Tennessee plan, won't qualify for anything. So do we raise money to buy their insurance for them? What about people who are above poverty but who still can't afford the premiums, even the premium tax credit? I can tell you that there are a lot of hospitals that would be glad to go out and pay those premiums. They're not sure whether legally they can do so or not. But that's among the many questions that we're going to be confronting if we don't do the Tennessee plan. There are lots of reasons to worry. There are massive new state and federal computer programs that have to mesh and cooperate with each other, complex transactions between the state and federal government. That all requires years of close cooperation, and what we've had is years of bickering and obstruction. The sequester of federal funds has put HHS on short rations and made it difficult for them to do a lot of implementation activities. In-person assistance is going to be critical. We know that from experience with the Children's Health Insurance Program and other public programs. Helping people, particularly people who've never had insurance and are not familiar with it, helping them make this system work requires one-on-one in-person assistance, and again, $1.8 million for in-person assistance across the entire state of Tennessee. And the state's opposition to Obamacare. A reporter called me the other day and said that he had asked the governor, will we be ready by October the 1st? And the governor responded, it's no concern of ours, that's all a federal show. Well, that's absolutely delusional. The computer, most of the people who apply are going to have to be sorted out for TennCare eligibility. TennCare is doing a whole new redo of its computer systems. It's taking eligibility as if it didn't have enough to juggle away from the Department of Human Services and moving it to the TennCare Bureau. So getting ready is huge, and we heard on good authority from friends in Washington that Tennessee is the one state in the country that has not yet told the feds about what they're going to do on October the 1st when the exchange tries to send them applications for Medicaid. the one state in the country, even Mississippi, even Rick Perry's Texas, even these other states that are all trying, Nikki Bailey in South Carolina, they were the ones that were just trying to outshout each other, hell no, we won't go, and they've all at least given that minimum. Our state has said, we'll let you know at some point. And then for the current enrollees, if you go to the next one, I'm sorry, you were right, back up. We're really concerned about people who don't have any experience paying premiums staying enrolled. They get enrolled, and they're going to need help continuing to make those payments. And then they're going to have to choose what plan, bronze, and within bronze, which different products, because companies all have to provide the same value in terms of actuarial value, but they may choose to mix and match. They may have higher co-payments, lower deductibles, a richer benefits plan. So people are going to have to choose that based on their own circumstances. But for the people that I'm most concerned about are the people who are currently enrolled in TennCare and Cover Kids, our children's health insurance program. If you go to the next slide, please. Because they're going to be reevaluated. They've got to cross a very treacherous process, a bridge from where they are now, because we're redoing eligibility for them. New rules in addition to the new bureaucracy and the new computer. And effective in January, the ACA overhauled that crazy quilt of 50 states, 50 Medicaid programs, and made the way we counted income uniform. It was understood when that was done that in states like ours that where there were various work deductions, child care deductions, and so forth, many people would become ineligible, but it didn't make any difference because they'd be picked up by the Medicaid expansion. We're not doing the Medicaid expansion. So now they have to traverse this new eligibility process with no safety net. The result, that's not the fault of the ACA. It's the NFIB strikes again. It's the Supreme Court decision tinkering with something. And I just have to say, as a lawyer, I have great respect for the court. I have great respect for the judges. They're beyond brilliant, and they are all very dedicated. Even the ones that I differ with very strongly on ideological grounds. It grieves me that in a footnote they said the reason why they were not going to allow the Medicaid expansion to be required as a matter of mandate is that they said, what the law said was if you don't do the expansion, then you will lose the Medicaid dollars you're already getting, the matching dollars you're already getting. And the metaphor they used was that's akin to saying to someone, your money or your life. It's wrong for the federal government to say to the states, your money or your life. There was nobody among those 9 justices in that ivory tower, and none of their 50-some clerks, who all are from the brightest, best cadres, law reviews of the leading law schools in the country, who had enough contact with real uninsured people to say, that's insensitive. Every day, in every county of our country, our healthcare system says to people who don't have coverage, your money or your life. Please don't use that as an abstract metaphor when you're talking about abstractions like state governments and the federal government. Not in this context. To me, it was just unbelievable. And that's because I've spent 35 years dealing with people who don't have coverage or they have coverage that's inadequate, and they literally have their lives shortened. They die sooner and live sicker if you don't have coverage. And that's well documented in the literature, but I think it just shows what a gulf there is between people of privilege and the lives that are being affected by these decisions. And so the effect of the NFIB was when it pulled out the Medicaid expansion, made it optional. This conversion of the way we determine Medicaid eligibility leaves the current enrollees in peril. So we've gone in Tennessee from celebrating 3 years ago that now our clients who we dealt with for years with this reality of your money or your life, we're going to get coverage. And now we're facing the prospect that people may lose coverage that have been secured to this point. And the people who are most at risk are the people who have disabilities. If they get turned down under this new system, they're supposed to be able to ask for redetermination under the old rules if they have a disability. Do you trust the state of Tennessee to tell them that? I don't. This is an exciting time. It's an opportunity to get people covered. It's also a perilous time. There's a lot at stake for vulnerable families. There's a lot at stake for our economy, and particularly in rural communities, for our healthcare infrastructure. And finally, I just think that if this fails, 100 years of effort, it will be so toxic politically, no one will touch this. It's no accident the Republicans have talked about repeal and replace, but they have yet to come up with what a replacement would be. They can't come up with a replacement. And the reason is that anything that would begin to address these three problems of cost, quality, and coverage would be totally unacceptable to the ideologically ardent Tea Party faction of the party. And anything that would be acceptable to that part of the party would be no reform at all. So this is a flawed piece of legislation. It is far too complex. For a whole host of historical reasons and political reasons, there are anomalies and glitches in it that, if it were normal times, would have been long since repaired in technical amendments that characteristically follow after a major piece of legislation. Given the gridlock, that's not happening. So we're going to have to make this work. And if we don't, I mean, 5 justices upheld the individual mandate. If one justice had switched, it would have been impossible for the federal government, as a constitutional matter, to ever address this problem. They would have said, you just can't do it. And we know from experience, individuals can't deal with it, business employers can't deal with it, states can't deal with it. We learned that with TennCare. And so what's really at stake here, I think, is the question of, has America lost its capacity to come together, confront a huge social problem? I mean, 6 years ago, I heard Senator Grassley, conservative senator, Republican senator from Iowa, say, we have got to reform health care. It's going to bankrupt us. It's making us economically non-competitive in global markets, and it's the major villain behind our runaway federal deficits and our long-term imbalance in our federal budget. We've got to come to terms with that. Well, now, of course, he's taken the oath with everybody else. He wants to bring it down. But we have got to be, to me, this transcends healthcare. Can we come together, acknowledge, despite our differences, this is a problem that can only be addressed at a national level. We need to find a national solution. If it doesn't work the first time, we need to keep at it. But we can't just continue to see more and more people priced out of the system and unable to get insurance, and businesses unable to compete because of the burdens of employer-based insurance system, and a healthcare system that is widening the gap with other industrialized countries. Where, I mean, the New York Times reports about medical tourism, of people going to third world countries, or even, they had a thing about a skier who wanted a new hip replaced, and he went to Belgium, and he was able to pay for the trip, and he still came out ahead. So, this is a serious problem. We've got to address it. We've got to make it work, and I think it's really showtime, and it starts October the 1st. Again, I apologize for starting late and keeping you so long.
Thank you so much.
That's probably all you can stand, but I'm happy to hang around if there are
All right, if
questions.
anybody has a question, okay, 1 or 2 questions.
I wonder how, we always talk about the movement back and forth between the borders between Kentucky and Tennessee, and if folks will shift in order to try to get access.
Well, I mean, we're going to be
To
telling
healthcare.
people to do that. I mean, if they have chronic illness and they don't have insurance, we'll tell them, you need to go to a state that has coverage.
Mhm.
And of course, most people won't because they're tied by family and jobs and everything else, but there's some people that are desperate enough that probably will. Particularly if, I mean, as we know, we've got lots of states around us, and we've got Arkansas in the west and Kentucky on the north. So I think if you look along the northern tier and you look out in
Can we
Memphis.
see the map one more time? The whole time you were talking, I was thinking about that map again and wanting to.
If you look at, it's
Oh,
slide 12.
Get a handout. Are there not here?
And I'm sorry that you probably can't tell without color
You can.
on the handout. Can you
The-
tell?
the- yeah.
I mean, basically, and I couldn't find one that had a legend that I could cut and paste in here. But if you just know the orange ones, I mean, you can tell. I mean, you know,
Yeah.
if it's
I
these
just wanted to
states,
see.
those
This
are
is
the
all
no
orange.
states. And you know, the California, New York have said yes, and so you just extrapolate from there.
Why are so many doctors against it? I've had so many of my doctors say, you know, it's just doom and gloom. Say if this goes through, you know, they don't know how they can stay in business.
Well, they're in for a rocky road, period. Because there's going to be, again, the bubble has burst. And what we're seeing is practices being acquired by hospitals, and these systems are going to aggregate more and more. Physician autonomy already compromised by insurance companies is going to be further compromised, and there's going to be more accountability to large. I mean, basically, they're developing these things called accountable care organizations. I mean, this is the whole quality economy piece of this I didn't talk about. There have been lots of experiments around the country that on a small scale, in Utah, in central Pennsylvania, in Rochester, Minnesota, with Mayo, there are places that have shown that you can drive costs way down below the national average and greatly improve quality. I mean, you would expect that. If we spend 50% more than other countries and they get better outcomes, the good news is there's lots of opportunity to improve our performance without spending more money. And so the idea is that you pull together, instead of having all these cottage industries of a medical practice over here and a hospital that's freestanding over there and a lab over here, that you pull them together and you pay them in a way that says we're going to pay you based on your ability to manage a patient's care across time and across the continuum of care. And so you'll get a fixed amount of money. This is very crude, but you'll get a fixed amount of money, and you all can sort that out among yourselves. And we know from experience that doctors can do a pretty good job of holding other doctors accountable if you give them metrics to work off of. We know that on a small scale. We don't know how it's going to work on a large scale. There are a lot of people that are concerned that when you aggregate more and more, consolidate more and more, then, I mean, that's a violation, normally would be a violation of antitrust laws. You run into monopoly or oligopoly abuse and prices go up. There's a lot that's not known about this. There's going to be a whole lot of shaking going on. And if I were a doctor, my son is a physician, just finishing his residency, I think there's going to be a lot of tumult and turmoil. There would be anyway. The system was unsustainable. I mean, before these changes, they haven't taken effect yet. And already we've seen huge shakeups. I mean, witness what's happening at Vanderbilt. So I think doctors are right to be worried. I've been surprised, but not much, because my experience over the years has been that doctors are good clinicians, but because they're good clinicians paying attention to the medical literature in their practices, doesn't mean that they know, frankly, very much about health policy or health economics, which is complex in its own right. My son, the only exposure that he got at UT Medical School to any of this was when I was invited to give a 1-hour lecture there. All the rest of it was anatomy and, you know. And so, with all due respect to doctors, I think it's a reflection on the fact they're focusing where we want them to focus. But we endow them with knowledge of all things health related, and I frankly think many of them have not been very well educated on some of this. An example of that is the Tennessee Medical Association did not take a position on the Medicaid expansion. Well, I can tell you, just purely from an economic standpoint, that has huge implications for them. Certainly the ones that practice and have hospital-based practices, or for that matter, primary care physicians that are in rural areas, they're gonna see their hospitals closed, a lot of them. And that has enormous implications for them if we don't do the Medicaid expansion. They've now belatedly come out in support of the Tennessee plan, but I think that's because they bought the notion that this is a private thing, it's not like that bad Medicaid stuff, which is all window dressing, frankly. So, I think they're right to be worried. I think it's sort of unfocused anxiety. I think it's not very well informed. I think it's going to be rough sledding for them. I think it's going to be rough sledding all the way around.
So on that happy note. Well, okay, we'll take
And
one.
everybody else leave if you want to. I'll stay around.
Could you talk just a second about, I've got a daughter that had an existing plan through the Farm Bureau. Blue Cross Blue Shield is actually the provider. But she's got a decision to make whether to stay in the Farm Bureau plan as a grandfathered plan or to go to the marketplace.
Well, what I would do is, you can go right now to, the handout has a website for healthcare.gov, and there are calculators, and the Kaiser Commission has a, which I think also check out. There are calculators where you can go online and you can put in some information, and it'll give you an idea of what your premium tax credit will be, and you can look at what the benefits are. If she is in the band of, between 100% and 400% of poverty, where she gets premium tax credit, she's probably going to do better going to the exchange. You only get the premium tax credit if you purchase through the exchange or through the market.
If you go to the marketplace, pre-existing conditions
Don't count,
don't count.
don't count.
So that's a big benefit.
That's a big benefit. I mean, my hope for all this is, and I've got lots of friends who work at HHS implementing this, and I will say that it has been a bizarre experience. My experience of the political system is that most politicians get an A+ for marketing and a C- to an F for delivery. That's the way the world works, always has, always will. On Obamacare, the folks that I know that are working on the regulations and implementation are just top notch, and they're working literally 80 hours a week. They're as smart as you can, and they are the most patriotic, altruistic, committed to making this work folks in the world. And the marketing has just been crap. I mean, the opponents have defined this. Polling has locked in. I mean, it's the old adage in politics, you don't define yourself, your adversary will. And the adversaries define this thing early on. And the polling has been static for 2 years. And half the people think that Obamacare, once it takes effect, well, first, they think it's already taken effect. They don't know that it hasn't taken effect yet. They think that when it does take effect, it's going to cause everything from male pattern baldness to the end of life on the planet as we know. And so my hope is that the expectations, by winning the war of PR, by creating low expectations, maybe people will be pleasantly surprised as opposed to angry and frustrated when this thing actually takes effect. There's a lot to be angry and frustrated about because the glitches that are known can't be fixed without going back to Congress, and it's gridlock. So there are just plenty of things. I mean, in my office, we're doing all these webinars. We're trying to be the folks in the state that can provide technical assistance to other people. And I mean, I've been doing this stuff for 35 years. It's really complicated. People are going to get frustrated. But I hope if they start from an expectation that, oh gosh, this is going to be terrible, well then, for most people, it's going to be a net improvement. For most people, it's going to be a net improvement. And for some, it will be transformative. It will be life-saving.
Isn't there anything, any organization any organization could do when the state has said you cannot have these people to help the navigators?
Well, the feds have issued regs that say that states can't impose restrictions on the navigators that basically violate federal law. The problem, I think, is in a state like us where we have so little money for navigators, we're really gonna be counting on, they're gonna get like 25 hours of training. But then there are these volunteers, CACs, which are certified application counselors. That's what we're really counting on. I mean, church groups, civic groups, hospitals, staffs, volunteers. And who knows, I mean, there's an effort afoot right now, starting today, that I'm a part of, to try to head this off. But, Primary Care Association talked yesterday to the insurance department, and they're working out the same playbook as the Georgia commissioner, who said our task is to obstruct this. So they're gonna charge every volunteer $50, they're gonna have to be fingerprinted, go through a background check, which will probably cost about $150. People are not gonna do that. They will not, one version, and I don't know if this is true, is that they will not be able to input the information. You can apply online. The plan was that people would take tablets, go door to door and help sign people up. You're not allowed to enter that. The people have to enter themselves. You're gonna take people with disabilities who are illiterate, and they're gonna, this is so disappointing, because I keep thinking back to Senator Grassley. And I know people in the legislature. I know people, I differ with them ideologically, but, I think most of them want to do the right thing as much as politicians ever want to do the right thing. But we are really in a bad place right now, where the ideology and partisanship have, we hear it all the time, but this is an issue where it's just plain. It's very weird. That's a great description. And much more polite than the one.
I found out recently that the certified application counselors in Rutherford County are to be found at the primary care and health clinic. But now you say these new regulations that are being worked on, are they going to take those people who are already in training?
That's forget that you
charge
heard
that fee?
that, because we're gonna try to head that off. But I can tell you that there are people in state government that want to make that impossible. And if we can't use CACs, and we're left with 18 navigators statewide, then it's not going to be good.